but we'll get through it. Lung cancer trials. So we'll go over screening, neoadjuvant immunotherapy. What does all this mean? Perioperative, EGFR, neoadjuvant, stage 3 split, metastatic immunotherapy, EGFR metastatic. We'll look at the ALK 7-year data, small cell lung cancer, and we'll try to include some of the latest data. And let's try to understand what this means, because if you're sitting there at those lung cancer conferences, which you used to understand and now you don't, and this will help you. So neoadjuvant treatment before surgery, shrinking the tumor, eradicating micrometastases. So examples are chemoimmunotherapy. And then what we say targeted, we mean like EGFR or ALK, that sort of thing. Adjuvant is treatment after surgery, so it reduces the recurrent risk. Things like chemoimmunotherapy and targeted osimertinib, EGFR, lorlatinib, a third generation ALK inhibitors. So then you have perioperative, which is before and after surgery, the sandwich strategy, giving neo, meaning before immunotherapy and chemo, surgery, and then doing adjuvant after, like the sandwich strategy. KEYNOTE-671, we're going to see that. Immunotherapy activates the immune system against the cancer. So PD-1 and PD-L1 inhibitors, pembrolizumab, that's the Keytruda, nivolumab, I think it's Opdivo, durvalumab, and atezolizumab. Targeted therapy has EGFR, ALK, ROS, MET, KRAS, BRAF. And then you have this thing called bispecific, which bridges the T cell to the tumor. And this new medicine, tarlatamab, the one that you know about, cytokine release syndrome and some neurotoxicity. But then the staging cheat sheet is stage 1 and 2 is localized. You might, stage 1A, you might just do surgery alone, right? Stage 1B and above, then you're going to need some therapy as well, adjuvant therapy. Stage 3, resectable surgery is feasible, neo and perioperative immunotherapy. And then stage 3, unresectable, concurrent chemoradiation, consolidation, and then durvalumab. Stage 4, you're thinking metastatic, and then systemic therapy, followed by immunotherapy plus or minus chemo in the recurrence. And then you have, here's the trial landscape. So early stage, you have EGFR, meaning targets are negative. So then you would do the immunotherapy pathway, which would be CheckMate 816, KEYNOTE-671, and AEGEAN trials. And we'll take a look at that first. Then we're going to go into the EGFR ALK positive early stage, meaning resectable. And we're going to look at, so the first 3 trials were neoadjuvant trials. And then we're going to look at the NeoADAURA plus ADAURA, which are the neoadjuvant plus adjuvant chemotherapy, meaning after surgery. Then we're going to look at locally advanced Pacific trial, stage 3, unresectable for patients that have no EGFR positivity. And then if they have positivity, they're in the LAURA trial. We're going to take a look at all this. This is just the overview. And then for the metastatic disease, we're going to look at KEYNOTE-24-189 in this newer study, Harmony 6, and then we'll look at EGFR positivity, Flora 2, Crown. So these are all EGFR studies. These are the immunotherapy pathways. And then we're going to look at small cell lung cancer, tarlatamab. And we'll start out with screening, but how to think of every non-small cell lung cancer. First of all, you look at their stage. So they're going to test the EGFR ALK RET. They're going to be surgery plus adjuvant, targeted, or immunotherapy. Stage, that's stage 1 and 2. If they're positive for EGFR, we're going to look at NeoADAURA and ADAURA. Stage 3, we're going to look at, is it resectable? What is the path on surgery? If it's unresectable, you're going to think of chemoradiation and then consolidation. EGFR plus wild, or is it wild type? And then we're going to look at LAURA and Pacific, stage 4. We're going to test all the drivers, and we're going to think of immunotherapy plus or minus chemo. And if it's driver positive or negative, it will drive us down this path. And so without further ado, here's the clinical practice. So for stage 1A, surgery first, then molecular staging. If EGFR positive, you could discuss maybe some adjuvant targeted therapy, but the benefit is greatest in stage 2 and 3. 1B, the surgery first. So basically in stage 1, here's 1A, you're doing surgery. Stage 1B, you might consider neoadjuvant immunotherapy and chemo if the driver negative and high-risk features. Stage 2, 3B, you're doing the sandwich therapy, neoadjuvant immunotherapy plus chemo, then surgery. Then you're doing post-surgery adjuvant immunotherapy, or post, if you have EGFR positivity, you're going to use the targeted therapy. That's the basic overview. And if I'm going fast, you can go back and you could hear that again. But we're going to go through this over and over again. So first 2 trials to know are the NLST in 2011, followed by the NELSON trial 9 years later in New England Journal of Medicine. So the NLST, 53,000 plus high-risk smokers, and the Nelson had 15,000. Nelson was done. Both are low-dose CTs versus control. NLSTs showed a decrease in mortality in getting CT chest screening, and the Nelson as well. And more in women than in men. There was a 10-year follow-up in the Nelson trial. And you should know the USPSTF based on this: 50 to 80 years old, greater than or equal to 20-pack-year smoking history, currently smoking, or stopped within the last 15 years. So you should know some of that data. Screening is the only proven mortality reducing intervention in lung cancer. So we're going to start with this again, the landscape, early stage. We're going to look at if your targeted therapy is negative. So let's look at CheckMate 816. So this is neoadjuvant nivolumab. So we're talking about patients that are scheduled for surgery, non-small cell lung cancer 1B to 3A, 126 sites, 29 countries, 358 patients, 3 cycles of nivolumab, then surgery. This is important. Showed pathologic complete response 24% versus 2%, hazard ratio 0.63. The event-free survival 84% at 3 years. So why this matters: pathologic complete response, that means 0% viable tumor resection. That was the best intraoperative signal of cure, and it established this as a validated surrogate endpoint in non-small cell lung cancer. The standard regimen is nivolumab, 360 milligrams plus doublet chemo times 3 cycles. Then there is surgery, so that's the neoadjuvant. Then there's surgery, and then there might be some adjuvant IO or surveillance. There are no driver mutations. Those patients will have NeoADAURA, which we'll take a look at. And that is that. CheckMate 816. Is neoadjuvant only. The KEYNOTE-671, we're going to take a look at the next slide. That's the sandwich, but this is the first trial that came out, and this is in 2022. So this is the first proof that immunotherapy improves surgical pathology, 24% versus 2%. Paper number 3 is KEYNOTE-671 plus AEGEAN. So now we're talking about either pembrolizumab or durvalumab. You could see the pathologic complete response 18% versus 4%, similar with durvalumab. And so you give it basically before and you give it after. 2023, both of these trials in the same journals edition. Resectable 797, KEYNOTE-671, and the AEGEAN was 802 patients. Basically, it primes the immune response with tumor antigen still in situ, generates the tumor-specific T cells. Surgery removes the bulk disease, and then the adjuvant immunotherapy suppresses the residual micrometastatic disease in escaped clones Sequential attack is more complete than any single phase. And so basically we do immunotherapy plus chemo times 4 cycles. You do surgery, and then you get immunotherapy for 1 year, and this excluded EGFR positivity patients. And this is the curative intent standard for stage 2 to 3B non-small cell lung cancer. And you should know the pathologic complete response, about 18%. So this is what we call sandwich sequence. Now we'll look at EGFR positivity. What happens there? That is a different discussion. So that those patients will get osimertinib plus chemo versus chemo alone. Look at the pathologic complete response, 25% versus 2%. MPR as a surrogate, that means less than 10%. Partial response, viable tumor parallels the pathologic complete response. NeoADAURA, this is called the NeoADAURA, neoadjuvant, establishes that EGFR-driven disease responds to targeted neoadjuvant therapy, just as immunotherapy-driven disease responds to immunotherapy. Okay, so this basically adds, so you do osimertinib plus chemo, then surgery, then the adjuvant osimertinib. And this was published in 2024 by Tsuboi et al. And so if you're EGFR positive, you don't go by the CheckMate 816, you go by NeoADAURA. That's the takeaway here. The mean partial response, 33%. So that's the story there. So now we talked about CheckMate 816, KEYNOTE-671 AEGEAN. We talked about NeoADAURA and ADAURA. Now we're going to talk about locally advanced stage 3 unresectable. And then stage 3, and you're going to look at 2 different types. So if you have in the Pacific trial, that's no EGFR positivity, so you're going to look at immunotherapy, durvalumab, and then you're going to look at osimertinib if you're EGFR positive, and look at the overall survival, 48 months versus 29 months. If you're EGFR negative, but you have, you're put on durvalumab, and then if you have EGFR positivity, you could see that the osimertinib consolidation was better. So the official rule is never give durvalumab to the EGFR. EGFR patients were excluded from the Pacific trial. Inferior outcomes with IO. So you would want to be on the EGFR drug. So if you're EGFR positive, you go by the LAURA trial, which is osimertinib. And if you're EGFR negative, you would do Pacific. This hazard ratio of 0.16 is 7 times better than the hazard ratio of durvalumab. So if you had to root for something in a stage 3, you're rooting for EGFR positivity. You don't want to be on durvalumab. You'd rather be on osimertinib if possible. The hazard ratio, again, is 7 times better than the hazard ratio of durvalumab. So now we're going to talk about metastatic disease, the KEYNOTE-24 and 189. So this is where you talk about the difference between PD-L1. So if you have PD-L1 greater than 50%, pembrolizumab monotherapy, you could see hazard ratio 0.62, doubles your overall survival. KEYNOTE 189 was any PD-L1, and that was pembrolizumab plus chemotherapy, doubles basically the overall survival. And so if you have PD-L1 and greater than 50%, no driver mutation, you do just monotherapy. If it's less than 50%, then you do chemo and immunotherapy based on KEYNOTE-189. But if you have positivity, so the paradigm shift signal, so this PD-1 VEGF bispecific evonescimab plus chemo versus IO plus chemo showed an overall survival hazard ratio 0.66 in squamous non-small. So this is specifically for squamous non-small cell lung cancer, that the PD-1 VEGF dual blockade outperforms the PD-1 alone. So you wouldn't use the tislelizumab by itself. This is a new finding. So for metastatic immunotherapy, PD-L1 greater than 50%, you're using 1, pembro, all comers, chemo plus pembro. And then ASCO 2026, specifically squamous, you might be better off using this PD-1 VEGF drug, evonescimab. So be on the lookout for that. And then you have the FLORA and FLORA-2 trials and the CROWN. So first we'll look at FLORA-2. This is a EGFR metastatic. So now you have a targeted, and you could see progression-free survival is much higher in the FLORA. And then in the FLORA-2, it's even higher. New England Journal of Medicine 2018, FLORA-2 is New England Journal of Medicine 2023. So the FLORA baseline overall survival, 38 months. It's the best overall survival of any EGFR inhibitor at time of approval. 38 months in metastatic disease. And if you have in the osimertinib plus chemo, you get even 9 months more than if you would just use osimertinib. So you could see that you would do that. And osimertinib crosses the blood-brain barrier. So the CNS progression-free survival is superior to prior generations. So that would be an interesting finding. FLORA-2 intensification is appropriate for high tumor burden. Like, how do you know when to use the chemo? Multiple Mets, large primary, rapid doubling, asymptomatic brain Mets, younger fit patients who can tolerate chemo. So osimertinib monotherapy is maybe sufficient if there's single site disease. So that is the takeaway message there. So we went over osimertinib or osimertinib plus chemo. And then paper number 8 is the CROWN 7-year progression-free survival, 55% versus 3%. It's the most survivable metastatic lung cancer. Look at the 7-year progression-free survival with lorlatinib, the third-generation CNS penetrant, as opposed to crizotinib, which only had a 7-year PFS of 3%. The most dramatic progression-free survival, 0.28 hazard ratio. CNS response, 82%. Near complete CNS protection. When it says median PFS not reached at 7 years, meaning it's still going. People are progression-free. That's a good thing. So ALK positive is now potentially a curable metastatic disease. So why is lorlatinib better than alectinib? Because it covers most ALK resistance mutations, CNS response as well. So that's the big takeaway here. 7-year progression-free survival. Half of the people are still living at 7 years. So that's cure, right? I think 5 years is considered a cure. And then finally, small cell lung cancer finally has a targeted survival extending therapy, overall survival 13.6 versus 8.3. When you take a look at post-platinum and anti-PD-L1 progression, you're looking at this new medicine, DLL3, CD3 bispecific tarlatamab, and that is a target. This bridges DLL3 to the CD3 cell, forces the T cell mediated lysis. Thing you have to look out for is cytokine release syndrome. It's like a COVID response or neurotoxicity. Mostly occurs within hours of infusion. First 2 doses require hospitalization for monitoring. The second line treatment is now tarlatamab. Overall survival 13.6 versus 8.3. You should know that toxicity is about 50% of ICANN, which is some neurotoxicity, and CRS, cytokine release syndrome. So pillar 1 was resectable, driver negative, neoadjuvant plus chemosurgery, and then followed by adjuvant immunotherapy. We looked at CheckMate 816, KEYNOTE-671. The second one was resectable EGFR positive. So then you have osimertinib chemo and then adjuvant osimertinib. But then if it's resected, you didn't give any neoadjuvant therapy. Should you then use adjuvant? And the answer is yes. That's the last trial here. So pillar number 3, test all stages for driver mutations. So we went over the ADAURA trial, how adjuvant therapy helps, and this RET positivity, if somebody has a RET mutation, you could see there is definite free survival, event-free survival. So again, pillar number 1, driver negative, neoadjuvant immunotherapy surgery, and then adjuvant. Pillar 2, we went over, and then pillar 3 is any resected driver. You should give adjuvant therapy, whether it be osimertinib for EGFR or selpercatinib with RET. These are what you should test: EGFR, RET, ALK, ROS, KRAS, MET, and here's the current practice. Again, we went over this in the very beginning. Some other studies to know, just to be aware of: the KRAS study, CheckMate 17, but these make it the honorable mention because I'm just looking at the top 10 articles. Sacituzumab plus Pembro. So this is talking about building on the ivonescimab. But Delphi is looking at liquid biopsy. This is detecting lung cancer. This should be it's not yet the standard, but it should be an adjunct to low-dose CT in the future. So basically, we went over screening for lung cancer. We went over neoadjuvant immunotherapy, the first concept. Then we went over extending that to the neoadjuvant plus adjuvant therapy, KEYNOTE-671. Then we went over NeoADAURA, which was the EGFR positive population. And then stage 3, looking at the difference between Pacific and LAURA, whether or not you should use immunotherapy or you should use targeted therapy. Then we looked at the PD-L1, when you should use just by itself, and then that FLAURA 1 and 2, which was EGFR metastatic. Then we looked at ALK metastatic. That's the miracle one that could be cured. Then we looked at the new medicine tarlatamab for small cell lung cancer. And then 10, we looked at, if you resected it and you didn't give early on neoadjuvant, should you give adjuvant? And the answer is yes. And then if you want to test yourself here, take a picture of this and you could test yourself on 25 questions based on this lecture. Thank you for listening.